Sanjay, you had actually mentioned that early on, is that one of the key things here is obviously revisiting, tracking compliance, tracking adherence, tracking at outcomes. So at Oklahoma now that you're sort of the lead guy on the urology side, how are you planning on tracking your outcomes and tracking on the efficacy of your program?
Yeah, a lot of it we try to set up early on so we could prospectively collect data, study it going forward for many reasons, quality standpoint, even just also from research standpoint to study how we're doing. But yeah, we set up all these endpoints at the very beginning, and we have someone that comes by, one of our research associates comes and collects the data and also works with the administration to abstract the cost of all the various things that we're doing. But we try to meet it's hard to get everyone in the same room together, but every 6 months or so at least to take a look at it and see if there's things that are going on. And we found out that a lot of the kind of epidural or tap blocks weren't happening, and the reason is there wasn't a coordination with the pain team, and it was just a logistics issue. We also found out a lot of the physical therapists that we had on board that we had kind of more control over at our cancer center weren't necessarily translating the information or the plan over to the hospital side. And so things like that we found out, we learned about it, and we made the change. And I think that you find those things. You can also look at your endpoints and see if you're meeting your mark or not. And I think that it's really helpful for us just to look back at it and then tweak little things as you go along.
Traci, you're all using I'm assuming you're on some robust electronic record and sort of monitoring this from specialty to specialty and program to program at Virginia?
Yeah, so, going back to Sanjay's point, when we started colorectal, it was just my partner and I, and we collaborated with an anesthesiologist, and we chose 6 anesthesiologists that we knew would do the protocol, and we started with that. And at that point, it was before we were using electronic medical record, but we set into place systems level changes. So we made sure it was marked on the posting slip. We had a little sign on the patient's chart so that everybody knew that those patients were enhanced recovery. We had a checklist that we gave the patients. We had a booklet that we gave the patients. And as we experienced success, then the institution started to take notice, and we developed a program with a staff. And we, at that point, really incorporated it into our electronic medical records. So our checklist is now all electronic. The patients are identified on the electronic medical record. We have order sets, so it makes it nearly impossible for the residents in the middle of the night to order opioids without our knowledge. Just all these things to set yourself up for success so that it's difficult for patients to fall off the protocol.
We still have the sticker on the door, though, just to make sure that everybody walking in and out understands that.
I mean, from an ordering standpoint, is this something that when you're ordering a low anterior, or you're ordering a Whipple or a radical cystectomy we all have standardized order sets. Is that something that you're specifically having to mark as ERAS protocol?
Yes.
Well, I mean, it's just the way we take care of our patients. So, even our urgent cases. So we have one order set, the colorectal surgery order set, and it's enhanced recovery.
It's in there.
And then as we go from service to service, they build off of that order set and our educational materials. But the systems changes in our electronic medical record system are all transferable to each service.
John, how are you rolling this out at FIMED in terms of getting all your anesthesiologists, again, thinking the same way? And has this been problematic?
Well, it's a challenge. I mentioned it earlier. We're at several different systems.
Right.
So it's probably a little easier, well, there's nothing easy about implementation, but it's probably easier to get the anesthesia providers on board because we can do it centrally through FIMED than it is to implement at each local place. Not that that's difficult, and everyone wants to do the right thing, but it's different every place you go. So we've been fortunate in this position as anesthesia providers to kind of broker the organizational change at those facilities that, there's been a shift from where we're trying to implement and no one knows what we're trying to do to now we have facilities coming and asking us, well, can we do this here? And that's been a nice shift to see. And leading that organizational change is what we try to do in anesthesia.
And I'm sure when you make that paradigm shift in a system that's currently not doing, you get zero pushback from the surgeons, correct?
Well, that's a great observation. We're getting less because now they're starting to come and ask us for it. And it
Yeah.
refers to that competitive thing. They see what Traci's doing in Virginia, or they go to a meeting and they're saying, well, we got to do this. So
Yeah.
then they're coming and asking us, oh, well, we've been trying to do this for a while. It changes the dynamic.
Yeah, I think it's
entirely.
like anything else. You always, regardless of what the program is, you got to have a physician leader
Yes.
that takes charge of this and is really pushing. They've
Yeah.
got to push, and of course, you do get pushback.